I'm Danny West with Indepth Physio. You're watching another episode of the SOAPBOX, your patient education station. And this week we're transitioning a little bit into the ankle and shin bone. And again, talking a little bit about prevention and some easy self-checks you can do on yourself to see how you're moving in terms of particularly the shin bone today. So one thing I've started to really incorporate into my assessments, especially if there's any knee or ankle issues, is assessing the tibia and the shin bone. And I feel like this kind of gets forgotten about. It's not really a standard test that we learned in physio school. I kind of just have noticed it's been very useful through clinical experience, and so it's one of my go-tos for any kind of knee or ankle assessment. So we want to assess what's called tibial torsion. Okay, so if we look at the tibia in relation to the model here, it is kind of a long bone that kind of has a platform at the top. That's what our thigh bone sits on. Right in the center we have our kneecap, okay? But it's not only one shin bone, there's actually another one off to the side called our fibula, okay? And the main kind of shin bone that we can feel, that's our tibia. If we review from our foot lecture, again, the tibia is on the medial or closest to midline. Fibula is right here. The bottom part of the fibula is actually what makes up our outside ankle bone, and they sit nicely on what's called the talus. And we'll talk about that next session when we assess how much these can move on the talus, okay? But if we're looking at tibia, let's think back to my whole soapbox on no duck walking, okay? If we're constantly walking turned out, I just want you to have a look at what it's going to do to not only the ankle, but the knee. So if you think my foot's somewhere down here, and I walk turned out, do you see how it's actually going to torque, not twerk the knee into a little bit of external rotation? And then the kneecap that sits right on top, now we're bending and straightening the knee on kind of an off-kiltered platform. And I find that also contributes to a lot of patellofemoral pain syndrome, or in layman's terms, and the terms I like better, knee tracking probs, okay? So the kneecap should sit in a nice little gutter in here. And again, if we're throwing it off the alignment of the joint by walking with our feet turned out all the time, it's going to affect the tracking of that kneecap in the joint, okay? And so a lot of the time, if there's knee issues, I'm not only looking at the hip, but also I try not to forget about the shin, because it's also a very important piece of the puzzle, as you can see. So how do we assess this in clinic? These are magical things that, I don't know how this didn't make it into the physio school curriculum, but they're an amazing tool. They're called functional footprints, and they rotate open and closed. And not only there's a built-in goniometer in them, okay? So you can measure degrees of rotation. Again, they're called functional footprints. You can order them through Balance Body for a ridiculous amount. I'm sure somebody could make these. But they have been a super helpful tool when specifically assessing the amount of degrees capable at the tibia and looking at any asymmetry side to side. So what I would have the client do, I'll video it straight on first, and then I actually want you to see the visual that I'm getting from like an aerial view. But I would have them sit, obviously not in a rolly stool, but something stable. And I want to make sure that we're ideally kind of at 90 degrees of the knee. I'm going to place my heel in the center of the footprints. And there is little markings on here to line up with the second toe. The pedals also can kind of tip forward and backwards on these ones, which I like, because they kind of sense where your weight is through your arch. But I'm going to hold my knees in place, and I'm going to pivot again from kind of the heels. Try not to like grind the footprints, but keeping equal weight throughout the foot. And I would just kind of do a quick visual on day one and just see, okay, which foot looks more rotated than the other? Definitely my right. And again, if I wanted to chart exact degrees, my right has about 38 degrees of external rotation, whereas my left only has about 32, okay? and then I go back to center. Now, here's the kicker. I find people are usually pretty good at this one. It's almost easy. Some people are freakishly hypermobile there. But what about internal rotation, okay? I'm gonna keep my left foot straight on. I'm gonna keep the mound of my big toe down, and I'm gonna see how much I can start to turn my foot in. And I go back to center. And I'm gonna try the other side. This one's definitely stiffer. And back in. I just don't do two at once because some people can't get more range than that. And just a side note, these are meant to be set up 4 inches apart from each other, just to keep it consistent, which is why I have the tape there. So I'm gonna rotate in, again, watching they don't C-cup the foot to try to get more range. They really have to make contact with the big toe. They go in. I usually give them 3 tries, and then I take the 3rd attempt. So I'm about at 32 on the right. And then again, I'm gonna do about 3 here. And I'm just barely able to get 30 on the left. So I kind of have an idea, okay, I'm pretty equal side to side, but some people are like, they have 0 internal rotation of the tibia. And so my theory is if you think if we walked, turned out, it's gonna tighten up this whole lateral line, kind of mucks up the joint where the outside shin bone kind of matches up at the knee joint here. That's our proximal tib-fib joint. That can muck that up. And it also starts to tighten up the whole lateral line on the outside of the shin. So again, if I'm walking like this, I'm basically torquing the knee joint out to the side. This is a right knee, okay? And so what I have to try to facilitate is actually get them to self-mobilize their shin in internal rotation. This is gonna help just mobilize the joint back to where it should be. Also starts to help kind of loosen up all the lateral fascia. And I would do soft tissue release all along this lateral line, but particularly in through tibant and peroneals, okay? And I find even just working the shin, if that's their main restriction, and again, it's not the hip, which it's usually a bit of both, but sometimes I have a lot of luck if I treat the shin, I start getting them to do toe-ins under their desk at school or at work. It really starts to take the pressure out of the knee, and again, start to free up where that kneecap is tracking. So I'll quickly just give you an aerial view of what I'm seeing. Right, so you can basically see how my second toe is lined up with the marking on the top, and my heels are lined up in the center of the footprints, and they're placed about 4 inches apart. And again, if I rotate, I get a visual of the degrees. Again, I usually kind of do 1 at a time, and then I test their internal. They'll just kind of knock together. So that's why I like to do it 1 at a time, watching they don't kind of C-cup the foot up to cheat the range. Okay. All right, so that's basically my soapbox on the tibia and how tibial rotation or torsion I find is often forgotten about when assessing the ankle and the knee. But you can see, again, how if we're off kilter in through that tibia, it's going to affect the mechanics not only of the knee, but the ankle as well. Okay, so I'm not looking for specific degrees necessarily. I just kind of have a look and see, are they hyper one way, usually in external, and do they match right to left? And then how are they with internal? Because like the hip, I usually find people are lacking in internal rotation. Same with the tibia. So that's kind of a self-mob that they would do. Again, they don't need fancy footprints to do that at home. Literally just pivoting on the heels, trying to keep the knees straight, and working on toe-ins, okay? That's my rant on tibial torsion. Again, stop walking like a duck, and we'll see you next week when we talk a little bit about the ankle itself. Thanks, guys.